I wanted to talk about rheumatoid arthritis, but the media people didn't think that that sounded sexy enough, so they spiced up, says, could my swollen joints be rheumatoid arthritis? So hence the title. I had no input into that. So when we talk about rheumatoid arthritis, as you may know, there's over 100 different types of arthritis. And so when you start talking about arthritis, it's much the way people treated cancer probably 80 years ago, that if you had cancer, it really didn't matter what kind of cancer you had because you were going to die and that's it, whereas now some cancers are very treatable. So, and so much in the same way, when we talk about arthritis, it's really extremely important to understand, okay, what exact type are you actually talking about? Because the treatment programs are very different depending upon that. And that's why, as people come to our office as new patients, we spend usually typically an hour or more just trying to understand their story and what they have and what's going on. Because unless you really understand where you're starting from, you can't treat appropriately. But rheumatoid arthritis is a chronic autoimmune, symmetric inflammatory polyarthritis of variable severity. Now, that's a lot of words stuck together. Chronic, obviously, we know what that means. Autoimmune means that there is an immune response or self-immune response where the body is basically reacting and attacking itself. Say, for example, to clarify that or to contrast that to, say, osteoarthritis, which is more of a mechanical wear and tear arthritis. This is where the immune system actually plays an active role in causing not only inflammation, but also attacking the joints in the process. Symmetric meaning that it typically, over the course of time, involves joints on both sides of the body. I mean, it may start in one hand, typically the dominant hand, but soon it may involve both hands, or both knees, or both elbows, or both shoulders, for example. It's inflammatory, again, because of the autoimmune response. Polyarthritis means it typically involves more than one joint, typically more than 5 joints. And then a variable severity. Some people get a nickel's worth, some people get a dollar's worth. And that, again, is dependent upon the genes that they have inherited and the triggers, as yet unknown as to what they are, that set off the inflammatory autoimmune response. Inflammation of synovial line joints. Rheumatoid disease typically attacks what we refer to as synovial line joints, meaning the joints, each individual joint in the hand, and the elbow and the shoulder. But say, for example, there's only one place in the entire spine that can be involved with rheumatoid arthritis, and that's between the first and second cervical vertebrae, and I'll show you that later. And the reason that is because that's the only place in the entire spine that's actually lined by a synovial joint. And so what happens is, say, for example, if we're looking at the knee, okay, the knee is surrounded by a joint capsule, and I'll show this to you later. And the joint capsule is lined by a layer 2 to 3 levels thick of synovial cells which excrete fluid into the joint to keep the joint mobile. And what happens is this becomes grossly inflamed, again, by this autoimmune response. There is a worldwide distribution. It doesn't care how old you are, how young you are, what your socioeconomic status is, what your race is. It affects everybody. In this country, it typically involves about 1% of people. The other thing is that most people often think about arthritis being an affliction of the elderly. Rheumatoid arthritis typically affects women more than men, and it typically affects them during their peak childbearing years. So usually we say the 4th decade, or which would be the age 30s. 30s and 40s would be typically a time of onset of rheumatoid disease. Again, it can affect the younger, it can affect older, but that's the peak area of incidence. Okay. So the incidence is about 1% in North America. And again, it's about 2.5 times higher in women than in men. Probably about 75% of patients that we see in our office are women. And I tell people often don't think about this, but the only specialty that sees more women than I do are gynecologists. So, as of yet, no infectious or environmental causes have been identified. There's been a lot of speculation about that and a lot of research, but as yet we don't understand exactly what the trigger is. Most people look at this like, we know that there is a certain genetic predisposition that we all have. but it's not as careful or it's not as closely aligned to, say, something like eye color or hair color. It's much more polygenetic in its organization, but also we know that there is some undefined trigger. And so what we see, let me back up here and talk about the infection. There's been a lot of discussion over the last 10 years about whether we should be treating these people with high-dose antibiotics because some people have had a response to or an improvement in their rheumatoid arthritis when they take antibiotics. There's only been really one study that's proven itself in that regard, and that's minocycline, which is a tetracycline. And it appears to be most effective when used within the first year of involvement. And after that, if the rheumatoid disease continues past that point, it loses its efficacy. But the reason minocycline, as well as some other antibiotics, may be effective in supposedly treating rheumatoid disease is because some antibiotics are actually anti-inflammatory. So it's not so much that the antibiotic is treating the problem, it's that the antibiotic is an anti-inflammatory, which is then helping the rheumatoid disease. So talking about the genetics, okay, about 15 to 30% of monozygotic twins will have rheumatoid disease, meaning that if you're an identical twin and your identical twin has rheumatoid disease, your risk of having rheumatoid disease as well is about 15 to 30%. Okay. Again, symptoms vary from person to person and from day to day. So, and that's important to know. Everybody has triggers that are different. Sometimes it can be, if you're sick for some other reason, say you got the flu or something like that, your rheumatoid disease may be more active because your immune response is revved up fighting off the flu, and while it's in the process of doing that, it's revved up fighting your arthritis at the same time. Or changes in the weather. Barometric pressure primarily is one that does that. Also cold weather. But rheumatoid arthritis is a systemic condition, meaning it affects the whole body. It's characterized, and we characterize it by how it affects the joints, but it can affect the hearts and the lungs and the nervous system and things like that. So it's important to realize that. And so what we see, and I'll show you later, is inflammation of the synovium, or those linings, that lining of the joint capsule, is what ultimately leads to swollen, painful, warm, and sometimes red joints. But this is something that people often experience, especially when their disease is active. The fatigue, the malaise, the weight loss, sometimes even a low-grade fever. Okay. Now, once their rheumatoid disease is under control, we expect those constitutional symptoms to be abated as well. However, the thing you have to be careful about is that a lot of things cause fatigue and malaise and weight loss and low-grade fever. So, if you get strep throat, it's not your rheumatoid arthritis that's causing it, it's your strep throat. Okay. So this is the typical joint. Again, two bones coming together, diarthrodial. And this blue part here is the cartilage. And then you see the cartilage on the bottom side. And this just so happens to be the right knee, and we're facing the right knee. So what you see in this section, they've carved back the muscles and the tendons here. But what you see here is the joint capsule. And the joint capsule surrounds the entire articular surface, kind of like the covering of a basketball, okay? And then the synovium lines this joint capsule through here, all the way up to the margin of the bone here, and all the way down through here. And again, 360 around the joint, okay? Okay. Now, if you were to take a biopsy of that very thin synovial lining, what you would see is something like this. You see some very loose adventitial or subcutaneous tissue, but then you see these little row of little beaded dots here, these dark dots. These are actually the nuclei of the synovial cells, and they're just two or three levels thick. But they're the ones, again, that produce the oils that keep our joints mobile and loose. Now, again, but the tissue here is very fluffy, very loose, very unimposing. Okay. Now, this is what happens with rheumatoid arthritis. These synovial cells become very angry, very puffed up, very blue-looking through here. But then you see through here that loose, fluffy tissue, okay, is now packed solid with inflammatory cells. Okay, and it's this degree of inflammation and swelling that causes the pain and swelling and stiffness that a patient with rheumatoid arthritis experiences. Okay. Now this is a cartilage of a bone, and this is cartilage that's under distress because it's much redder, and then this is the cartilage that looks healthier. These are chondrocytes. These are cells within the cartilage that make cartilage, okay? But what you'll see is this rheumatoid inflammation is starting to invade into the cartilage. It's eating into the cartilage, okay? And that's referred to a rheumatoid pannus, or P-A-N-N-U-S. Okay, and so when it eats into the cartilage, ultimately it's going to eat down to the level of bone, and when it does that, it actually shows an erosion on the bone where the bone has been eaten away. Okay, and that typically occurs at the margins of the joints and works their way in. Okay, so if you're looking at synovial tissue, this is through an arthroscope of a knee, and you see the cartilage here in a normal patient. It looks very clean, very white. When you look at a normal, it looks extremely white. It's almost looked like it's just Charmin toilet paper white. I mean, it's just very clean, very pristine. It's like the glistening end of a chicken bone, if you've ever seen that. Okay, and then you see some synovial lining here, but then you get to something like that, and it's just heaped up and just, you know, these fronds are sticking out. It's just all inflammatory cells, and they're inside the joint, excreting a lot of enzymatic chemicals that are causing the degradation and destruction of the cartilage from the acid and the chemicals. Okay. So what happens over time is, again, you see these synovial cells become really heaped up and inflamed. Not particularly. Heaped up and inflamed through here. And again, what happens is it starts to eat away at the bone, causing an erosion here at the margins. Okay? And you see also the chemicals being released by these synovial cells are also starting to erode away the blue cartilage as well. And then what you see over time is that the cartilage is basically worn out, okay? But then at times you start to see fibrosis, and it's not quite as angry. This is what we refer to as burned out rheumatoid. And what we see in some situations, people that have had very active, aggressive disease, later in life, they're left with the deformity or the ankylosing or the limitation to range of motion. The joints they're bonier and they're knobbier, but they're not as inflamed or as irritated as they once were. But they're left with the mechanical wear and tear effects of this condition. Okay. This is a real interesting shot. This is classical changes of Microsoft Windows, and so what we see here is you see some swelling of the dorsum of the wrist through here. You also see swelling of the knuckles here compared to here. We'll show that, and also see what we call classical ulnar deviation. And what happens with that is that as the big knuckles become swollen, the ligaments and the tendons around these joints also become loose and a little flabbier, if you will. But what happens is that when you squeeze the hand, the outward forces are such that it tends to sweep the fingers laterally. Okay? So what happens over time, the pull of the tendons literally pull the fingers over because there's so much looseness in the ligaments and the tendons. Now, what's interesting about this picture is that this is a person who had a stroke. Okay, they had rheumatoid arthritis and they had a stroke on their left side, and so as a result, they used their right hand more. And you can see what's happened over time is that the right hand, even though there is some swelling, the anatomy and structure of the hand looks almost pristine because they just didn't use the left hand as much. And because the right hand had to make up for the left hand, it did double duty, and you see the ulnar deviation, you see the swelling here, and the persistent inflammation that you don't necessarily see over here. Okay. So when you look at x-rays, and I don't know why I threw the slide in, but anyway, class 1 is no abnormalities. Class 2 is we start to see some thinning of the bone, meaning that the calcium density of the bone is not as strong, as it looks as osteoporotic, and that's because of the inflammatory response. When you get swelling, when you get a lot of inflammation, it basically leaches some of the calcium out of the bone, so the bone looks not as dense. Okay, and you may see some slight destruction. And then what you see over in class 3 is that, again, the same thing. There's cartilage degradation, there's bone destruction, there's deformity, and you may see some atrophy of the muscles because the hand is not, or the hand or the joint is not as functional. And then what happened, like we showed in that last slide, where the rheumatoid arthritis is burned out, you may actually see ankylosis, where the joint fuses itself and it can't move. Okay. Now, and sometimes it is distorted as it sounds, sometimes that's a blessing. Say, for example, you know, if you have ankylosing in a wrist, sometimes what happens, because the mechanical wear and tear is so severe and so painful and so limiting, once you actually have the ankylosis, the hand and the arm become much more functional because the pain's gone. So that's why some people get wrist fusions. Yes, they can't do this any longer, but because the wrist doesn't hurt, they can pick up their grandchild, or they can, you know, do yard work or do whatever they want to do. Okay. This is one of my most interesting pictures in this slide set. It's because it really explains to people what we're trying to do over time. This is the same joint over a matter of a few years. Okay, what you see is you see a fairly normal looking joint at the time of diagnosis, a minimal amount of soft tissue swelling, but the joint space is nicely maintained, it's fairly wide, and no evidence of any erosions or anything like that. Taken a year or so later, you start to see a little bit more whiteness of the bone through here, and also through here. You also see this joint space looks a little bit more narrowed, and if the lights were better, you'd also see that there's more soft tissue swelling. Okay, but by the time you get to the third slide, you see certainly more marked narrowing here, certainly more whiteness of the bone, but now you see this large erosion here. Okay, so with our goal of trying to treat rheumatoid disease is we we want to treat it here rather than here. Okay, this is a technetium bone scan. Sometimes they use this. More commonly now, it's used when people are doing types of cancer workups, looking for metastatic or cancer involvement of the bone, because it tends to light up like this. But before we had before we had MRIs and stuff like that, sometimes the only way that we could prove that somebody has true inflammatory changes in the joints is to get a technetium bone scan. And so what they do is you're injected with this material, and this radiographic, radiation material, and what it does is it seeks out inflammation. And what you'll notice in this particular version, you can imagine this is the hands. This is within the joint capsule of the wrist, okay? The big joints of the fingers, the metacarpal phalangeal joints, okay? And then the PIP joints are these joints right here. And so what you're seeing is that that's showing these joint areas of inflammatory response. And it's a very sensitive test for this. And so what you also notice in the bones where there is no evidence of where there are no joint capsules and no inflammatory response, the bones of the hand or the wrist or whatever, or the long bones of the arms don't light up because there's no synovial line joint. There's no inflammation. There's no inflammation in the bone right here. The inflammation is at the joint. Okay. This is referred to as fusiform swelling because it looks like a diffuse tube. Okay, you just imagine somebody just kind of slipped. You had just this tubular swelling through here, and we often see this in early rheumatoid disease. And you see a little bit more pinkness to the PIP joints here. Very painful, a lot of stiffness, a lot of discomfort with activities of daily living, or even just trying to sleep at night. But usually with that, you don't see the bone changes because it's just too early in the disease. Okay, so again, this is a pre-erosive change. So if you look at the joints here, the joint spaces are nicely maintained. There are no erosions, but what you do see is you see the soft tissue swelling. Okay. Okay. Again, ulnar deviation like we saw before. And with this ulnar deviation over time, what happens is you start to get subluxation, meaning that the fingers, where they connect to the hand, they start to slip down. Okay? And that's why they look at a lower level, and then you start to see the ulnar deviation again. And in this woman here, what you see is you also see some rheumatoid nodules at the tips of her hands. Rheumatoid nodules typically occur in areas of pressure. So sometimes you get rheumatoid nodules on the elbows because people are leaning on chairs, or they use their elbow to get up as they get out of a chair or off the table or on the table for that type of thing. So that's what you see there. Okay, so here we see more radiographic things where you see the ulnar deviation, the sweep. You start to see the narrowing of the joint space and the evidence of early subluxation, where again the joint, instead of lining up like that, starts to slip down. Okay, and then you start to see the cystic erosive changes, like that little bubble there or that little bubble there. Okay. And this is referred to as arthritis mutilans. We most commonly see that in patients with psoriatic arthritis, although we can see this in certain patients with rheumatoid disease. Again, it's the same types of things I've shown you before. It's just a much more exaggerated response. Okay. I told you that there was only one place in the spine that can be affected by rheumatoid disease, and that's at the base of the skull at C1, C2. So what you see is, you see the atlas here. The atlas is C1, okay, so it sits at the top right at the base of the skull, okay, and so it's just a circular ring. And then C2 has a spike that comes up called the odontoid, and it attaches right here, and that odontoid allows the axis to move, so we can rotate our head, left and right. People with rheumatoid arthritis that have this kind of discomfort, they typically don't complain of neck pain with flexion or extension. They complain of neck pain with rotation, because that's the exact location where rotation occurs, is at C1, C2. The danger of this, and here's that synovial lining I was telling you about around the dens here, the little blue circles here, okay? And then this is a ligament, because this ligament keeps that odontoid up flush against the atlas, okay? What happens is that this starts to erode, this inflammation in this synovial lining starts to erode the ligament here. And then what happens is, all of a sudden the odontoid is no longer held in check right here, and all of a sudden it can start to move. Okay? Now the problem with that is that this is very high-priced real estate. This is the spinal cord. Okay? So all of the activity below this level, okay, all of the nervous activity comes through that region. So what happens is that if people lose this ligament and start to get hypermobility of this segment, then you run the risk of neurological damage. And that was a real big issue back in the 70s and 80s and stuff like that, when we were concerned about when we had more people with active rheumatoid disease. They go into surgery and they go under anesthesia and they tilt their head back, and sometimes that would be a potential risk for the anesthesia for the surgery. So again, we don't see that. We really don't see that much anymore. It's really quite rare. I have 2 people in my practice right now that I can think of that have this C1, C2 instability, but it used to be a much more common problem. Okay. And actually the area in question is not here. The area in question is right here. This is that atlas seen on edge, like here. Okay. So here's the back end of it, and it comes out like this and sweeps around to the front and goes around. So it's like that. And then here's C2, and there's that odontoid, that spike that I was telling you about. Okay, this should be much closer to this, and you don't have a point of reference here, but certainly, once it gets to about 3 millimeters, that's too far. We want the gap to be much closer. And so what you will see on most normal spine X-rays is that the gap is maybe 1 or 2 millimeters, not as wide as we see here. And you see what happens is, the person is tilting their head down, okay, and you're starting to see that as she tilts her head down, you start to see that odontoid start to move. Okay. Hip. What's different about this that we see with patients with rheumatoid is that the erosion of the cartilage tends to be much more symmetrical. And with osteoarthritis, for example, one side of the joint will wear out first, and so one side of the joint looks normal, the other side looks worn. Okay, with rheumatoid disease, you see a thinning of the entire joint over the space of the joint. Okay, and then what happens is you see more thinning, so now you're nearly bone on bone here. Okay, and then all of a sudden what happens is there is no joint space. You start to get all this bone degradation here, and so people are looking to get their hip fixed, obviously, hopefully before this. And then worst case scenarios, you see the next one. This is referred to protrusio acetabuli. And what happens is where the femoral head actually starts to erode into the pelvis, so it's actually shoving through the pelvis. Okay, and I've had two women with that. Actually, one I don't think the orthopedist ever talked to me after that. She was 93, but she was in excellent health, you know, and she was completely hampered by this hip that was just worn out, and he had to go in and basically rebuild the pelvis and replace her hip, and she just did great. So anyway, it does happen. Okay, knees again, unlike what we see with osteoarthritis, where you can have where like one part of the joint's worn out and the other part looks normal. With rheumatoid involvement of the knees, you see symmetrical joint space thinning and erosive changes. So again, as I talked about at the top of the hour, you know, it's vitally important with medical history and examination to have an understanding of what the patient has, so that you can direct their therapy. We do blood tests for a variety of reasons. One, to help confirm the diagnosis, and that's often unusual for people to understand that. They often think the diagnosis is made by the presence of a rheumatoid factor. The problem with that is that about 1%, as I said, about 1% of patients with rheumatoid arthritis in this country. But if you were to go to the mall and track down the first 100 people you saw and took their blood, about 5% would have a positive rheumatoid factor. Okay, so there's a lot more people running around with a positive rheumatoid factor who are never going to get rheumatoid arthritis. So this doesn't make the diagnosis, it confirms the diagnosis. Okay, as long as we feel that they have the criteria for that. Then we have chronic and acute inflammatory markers. And then we also do other blood tests to exclude other diseases, and so that's why we do that. Or to monitor drugs. I mean, can I put a patient with rheumatoid arthritis on drug XYZ? Well, we have to know that. You know, we have to know what their, you know, will their liver put up with that, or their kidneys put up with that, or do they have a history of infection or tuberculosis or whatever like that. So often requires a few blood tests and, of course, radiographic studies, as we talked about. There's no cure for rheumatoid arthritis at this time, but having said that, there's never been a better time for rheumatoid arthritis than now. Not that we don't have a long way to go. When I came here in 1991, one of the things that jumped out at me was we didn't have enough wheelchairs in the waiting room. And that was really discouraging for a variety of different reasons. And now one of the things I like about walking through the waiting room is I get to see the wheelchair sitting in the corner not being used. And that's you know, it's kind of it's a daily reminder. Now, I mean, do we have some people that need wheelchairs? Absolutely, but it's not like we used to. Okay. So we have some highly effective treatments. Again, all medicines have risk and benefits, and I'm not trying to sit here and tell you that, you know, it's all peaches and cream with medicines. But you know, my philosophy of medicines is I don't trust any of them. So, I mean, I watch them all closely, and so do my partners. But the other thing is that effective treatment early is critical. There are more and more studies suggesting that treatment within the first 2 years makes a significant difference in how that person responds 20 and 30 years down the road. Okay, so you don't want, you want to attack it quickly. Again, treatment methods, obviously relieving pain, suppressing inflammation, slowing joint damage, and again, most importantly, improving patient function and sense of well-being. That's the key. I mean, this is about people, so it's not just about joints. It's about people. And again, individualized treatments. Sometimes this person needs this type of therapy, and sometimes this person needs this type of therapy, depending upon the degree of their rheumatoid involvement and their particular history. So it's interesting to see that. Okay. So what medicines are used? Well, there are medicines certainly that we use to treat symptoms, the first one here, and then medicines that were actually used to modify the course of the arthritis. Okay. Go to the next slide. Okay. Traditional anti-inflammatory pain relievers, ibuprofen, Aleve, aspirin, things like that, that helps control the symptoms. It doesn't treat the underlying process. Now, there's nothing wrong with treating the symptoms. It's just you have to understand that treating the symptoms is treating the symptoms, but it's not, you know, I had a professor at Mayo used to say that, you know, treating the symptoms alone is like, you know, using a water hose to put out a fire in the house. You know, I mean, you're hosing down something, but you're not treating the underlying thing. And the other thing was, you know, don't rebuild the house while it's still burning. And of course, analgesics like non-narcotic or narcotic analgesics sometimes are important to help treat the symptoms. Steroids are in blue for a reason that traditionally we use these as symptom relieving drugs. However, what most people don't realize is that steroids are really disease modifiers as well. The reason we don't treat them as such is generally because long term the side effects of steroids outweigh what we want to accomplish. Okay? So we try to use steroids as low a dose as possible and for as short a time as possible. Now, does that mean that everybody gets off of steroids? No, but we certainly strive to do that. Okay. Now we have what we refer to as the traditional disease modifiers. When I came here in 1991, that's what we had. We had traditional DMARDs. And you were being really aggressive at that time if you were using methotrexate. Okay? You see, gold is not even on here anymore, mainly because there's so few people using it and no one's making it anymore. There is oral gold called Aranophen still left, but we have much more effective medicines. You see minocycline, I kind of talked about that earlier. Again, just for early disease, it's not a good long-term therapy in my opinion. And then we have some stronger things like Cytoxan, which is a very aggressive chemotherapeutic agent. The problem is with Cytoxan, it does affect the blood count significantly. And for women of childbearing years, that could be a real problem because it could make them potentially sterile. So obviously, if rheumatoid affects a majority of women in that situation, then obviously that's not a good long-term solution. But you've also seen probably the triple drug regimen of methotrexate, hydroxychloroquine, and sulfasalazine. This is a regimen made famous by UNMC, and there's been study after study showing its utility, and it is a helpful regimen. They believe that it's better than the use of biologic agents such as Enbrel or Humira or something like that. I don't agree with that assessment, but in most rheumatologists in the country don't either. However, that's not to say that for some people, this is a very good regimen. And for a lot of people, I try to go there first, okay? But I realize, you know, I have more than one arrow in my quiver. I'm going to use whatever it takes to get the rheumatoid disease under control. Oftentimes, I will start with methotrexate, and then I'll add these two later if methotrexate alone is not sufficient. And if we go to triple drug therapy and that's not sufficient, then we start entertaining the idea of a biologic agent. Now, for some people, methotrexate is not well tolerated, and so we go to something like leflunomide, which has very similar characteristics as far as the number of people it benefits, but it's a completely different medicine. And azathioprine has been around for a long time. Actually, it's one of the few medicines that has true rheumatoid approval by the FDA. However, azathioprine is most typically used in today's world in treatment of transplants, in transplant medicine. Okay. And then we get to the biologic agents. And again, when I first came here, you know, the first couple of years I was here, Enbrel was the first medicine on the market, you know, as far as a biologic agent. And it literally revolutionized the way we treat rheumatoid disease. It was truly a renaissance. And now not only do we have a multitude of other agents, we have a multitude of other agents that work in various different ways. Okay, so it's not one, you know, it's not all vanilla ice cream. I mean, we have vanilla, chocolate, Rocky Road, the whole bit, you know, so that's really good. I do have a funny story about this, and I'll tell you about it later. It's after we're off the thing here. Okay, so the anti-TNF agents, first ones on the market, we have 5 right now. Anakinra was one that came out. It's a daily injection. People really didn't like that. It's also very expensive, as are the others. But the daily injections really kind of put a hamper. Good rheumatoid drug. Actually, it looks like it's a better drug for gout, but it's a very expensive drug to be treating gout. But it's interesting. There's also another condition called adult onset Still's disease, which is like an aggressive form of juvenile rheumatoid arthritis that Kineret seems to be very effective for. Actimra has also been a nicely tolerated drug. It's an IL-6 receptor antagonist, and that's been out in the last few years. Very well tolerated and has been helpful for a number of people, especially those who have failed, other agents. Abatacept or Orencia, the brand name is called Orencia. Abatacept is an anti-CTLA-4 inhibitor. What's nice about that is that for this particular drug, it's one of the cleaner drugs in that group. And what I mean by that is that I have people with very few infections on this drug. So for my elderly population, meaning people in their 70s or 80s or older, that need a biologic agent, this is one of the first ones I go to because it tends to be very well tolerated. Rituxan right now is a medicine that we tend to use for people that have quite aggressive rheumatoid disease or who have failed other things. The advantage of Rituxan is that it's a series of 2 infusions, and they're given every 6 to 12 months depending upon what the need is. So they're long infusions. But if you only have to come in every 6 months for the infusions or every year, then it's a real advantage. One of the new ones out on the market is called Xeljanz. I don't know who comes up with these names, but that's completely unreasonable. But it doesn't mean anything. But anyway, what's nice about this, unlike the others, that this is our first oral biologic agent. Okay, it's actually a tablet. Okay. So most people take 2 tablets a day. Fast onset of action, usually within a week or 2, we start to see a benefit. It carries the same risk as all the others. People say, well, it's a pill. How big a deal can that be? But it carries the same risk as all the others, and also, by the way, carries the same expense. So, which is unfortunate, but. And so, not to forget, and this is really important, is non-pharmacologic management is really important too. I mean, appropriate rest, but appropriate activity. Exercise is important, physical or occupational therapy, and when needed, judiciously, orthopedic surgery. So, a lot of options, not only medicine, but also from a physical therapy standpoint or a surgical standpoint. And that's the end of the slides.